Have you ever noticed how your connection with a client impacts their treatment session? What happens when you didn't connect with a client well? In today's episode, I talk with Susannah Haarmann about the importance of creating connections with your clients.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started.
Hello, everybody. Welcome back to the podcast. This is Lynn Schulte, and today I'm excited to have with us Susannah Haarmann. Susannah is a board-certified PT, women's health specialist. She's also a certified lymphatic therapist as well. She has a private practice in North Carolina, and she is also the founder of Pelvic Health Resources. Welcome to the podcast, Susannah.
So much, Lynn.
I am super excited about this topic that we're going to be discussing today because it's just so critical. And that is connection to our clients. So what do you have to say about that?
Well, it's certainly not an area that I'm an expert in, and I don't think that anybody is. I think that it's a place where we can put our intention so that we can prevent burnout and improve patient outcomes. And I've just learned so much by working with other people in this field that there are just some tips that I want to share. And I think that, in the pelvic rehab profession, it's really critical that we learn those social skills and how to connect to ourselves and how to connect to our patients because it is such a vulnerable area that we're working in. And we want to be as, the best servants that we can be.
Absolutely. What do you mean by it can prevent burnout? How does that work?
Well, I think that the current medical model that we're working in, that paradigm is kind of like a top-down patient provider approach or provider patient approach. And it really lends to like, the provider being more of the active fixer role. And a lot of people think about the patient as being more of the passive role. And I think that that's something that we need to address in terms of working with our clients, that not even manual therapy is passive, and that with all of the other things outside of patient care, like productivity and billing and note writing, that all leads to burnout. And taking just having small little touchstones can really help establish connection with our patients and prevent burnout,
Mm, yes. I
or
was
maybe dim it down a bit.
Yeah. Well, and I do believe it's very heavy for us to think that we have to fix everybody and that, we have to make them better and we can lead horses to water, but we can't make them drink. And sometimes their pain is serving them in some way. And so we need to be aware of that. And I really teach an aspect of manual therapy, which I'm engaging my clients in the entire process and helping them to feel, how does it feel on this side and how does it feel on that side? And do you notice a difference? And really working on their interoception so that they can sense and feel the differences after a session, after a treatment, even, and noticing when the tissues are releasing as we're doing the work together. So I'm a huge proponent of not just letting them lay there and do nothing as
Absolutely.
I'm working with
Yeah.
them.
Yeah, I think that sometimes too, as providers, we have a really big knowledge base and we want to present ourselves as experts, but really it's the patient experience that matters. And, when I'm having these discussions, when I was thinking about coming in, I was thinking about all of the people that I have learned from, and two people came to mind when you were just speaking. And one was Jen Van Devent, or Jenna Ross now. And I used to teach with her, and I loved how she used to say, she'd say, okay, come on, Susannah, get on my back. And she was like, this is not what we do as providers. And then she would grab my hand and she'd walk beside me and she was like, this is what we can do as providers.
I love
And
that.
so, yeah, and so we walk with our patients and we witness them. And that doesn't happen a lot a lot of providers don't get the amount of time that we do with patients,
Right. Yeah.
level of intimacy, and then also Ramona Horton, if you've taken any of her courses, when she's talking about the fascia, she says that a patient never just lays on the table when you're doing manual therapy on them. And I think that one of the things that my patients really appreciate is when I say, I'm not making the changes. I'm helping facilitate the changes, but it's your brain that is helping to make the changes, coming down into, more of a parasympathetic state, understanding that you're safe, the fascia starts to change. And our patients can, do anything such as working on diaphragmatic breathing or tuning into their body. I've had some patients that can actually describe to me what quote unquote release feels like. And sometimes it'll be like a color or a sensation or even an image that comes to mind. And sometimes that image that can come to mind can tap into something that's really subconscious and important for the patient's plan of care that never would have come to the surface otherwise. And of course, just things like, contract, relax, working on fascia and having the tissue contract underneath your hands so that you can move into that next barrier and help it let go.
Yeah, so important. But as we were talking before we hit the record button, connection to our, so actually let me ask you this first before I go there. How do we connect to our patients?
Well, I think that there are some very simple things that we can do. Um, First off, I think that, as a teacher, when I was teaching pelvic health courses, one of the biggest things that I wanted to convey to the people who were in the classrooms, especially who were new, is that, it's when you're hands-on working with the patient, when you're in lab, you've learned all of these skills and they may be coming to mind in terms of a to-do or a checklist.
Mm,
But even our colleagues have stories. Our bodies have stories. Our nervous system is powerful. So being able to tap into that person's nervous system and make sure that they're safe is really important. I disassociated in PF1, and it was by the grace of Holly Herman coming around going, "Get your finger out of her vagina." And the lady was like, "What?" And, she was like, she was not present. She was not with you you know and so I think that it's very important to remember that it's not about our expertise or what we do and accomplish in that day. It's about it's about them. It's about our patients. It's about connecting with them. And when they first come in and we're first starting to get to know them, it's okay to connect and have a couple of sentences or take a couple of minutes just to kind of learn something about them or ask them about their day, just to kind of like, not make it everything clinical. Establish that rapport and that relationship and let them know that you're working with them, that you are listening, that you're asking, that you're inquiring about things. As far as the assessment goes, I think it's critical to explain to the patient what you're going to look at ahead of time before they ever doff their clothes.
yeah.
And then everybody knows this, but it never hurts to say get continual consent.
Yes.
And so and it doesn't have to be so blatant, but it can be like, okay, this is what I'm going to do next. This is why I want to do it. This is what you should feel. You know, are you ready? Or is that okay?
Yeah.
And yeah, and then, as far as the plan of care, of course, taking in consideration their goals. Something came to mind, but it left. Um, I'm sorry, it left.
That's all right. I want to go back to doing intravaginal work. And the way I teach it in my courses is I have like 4 or 5 check-in points with my clients along the way before I even actually touch their vaginal tissue.
Let's
And
talk about it.
and so it's, I start with them completely clothed the entire session and do all my external work. And if you've been listening to this podcast a while, you know that I always start with the pelvic bones first. and mobilize and get those back into place and balanced out. And then as I'm doing all that external work, I'm sensing into the body to see if they're even okay for doing intravaginal work. Like their body is getting used to my touch, getting used to me as a practitioner, and the body's sensing into safety or not. And so the other thing I want to just add to this is like our first touch, the first time we put our hands on the body is so critical because it tells that body everything about how they're going to feel for the rest of the session. And so we need to be aware of that. And what is your first touch like on the body? Is it aggressive? Is it, I'm going to find these tissues? Or is it a soft, gentle, welcoming, like, hi, body, I'm here to listen to you? Like you said, the body has a story, the nervous system has a story. And I feel it's our job to learn to read that story. And,
Absolutely.
and so
Absolutely.
going back to the intravaginal piece, I just had a client that had a ton of IVF trauma, and she was also a really good girl persona. You know, like she was a good girl. She did what she was told, and she knew she was coming in for intravaginal work. And so I missed two of the signals about her body until I got her disrobed and draped. And then I went to touch. I always start at the top of the knee, by the knee, as my first touch. And I went to touch there and I was like, oh my gosh, we can't do this. Like her body was like, no. And I had missed the other signals. And when I told her that, I'm like, your body is saying no. And she goes, oh, but please, please, that's why I'm here. I want you to do intravaginal work. And I'm like, no, your body's telling me no. I've got to listen to your body. She came back the next time and said that was the most powerful experience she's ever had.
Yeah, she had someone listening and paying attention to her, and you gave her autonomy and control. And that's one of those situations that I think that we can all expect to get into at some point is, where someone is saying yes, but their body is saying no. And, you as a practitioner needing, to kind of read the situation and determine what is safe for both of you.
Yeah.
Um,
And that's a deeper connection. So it's not only connecting to the person itself, but it's connecting to their body in a way that we're listening and reading their body. So
Absolutely.
that's
Definitely.
key. That is key. So,
So the two thing I remember what came to mind earlier.
oh, good.
And going back to that initial touch, like usually the initial touch for me starts after a postural assessment and I'm looking at the spine or the, sacroiliac joint. And I'll say something like, may I, like if I'm going to get
Yeah.
my hands on their sacroiliac joints, may I lift up your shirt, to give them control. And just something that bothers me a little bit when I've had someone do it with me in therapy is say something like, can you do this for me? And I say, in my mind, in my own practice, that could be totally acceptable for some people, but for my own practice, that's something that I try to avoid. And I may still do because the patient isn't doing it for me. They're doing it for them. And so if we consistently say, can
Got
you
it.
do this for me, for me, for me, for me?
Got it.
It, yeah,
Yeah. That's important. I thought, I was wondering, like, what's wrong with that question? But the for me, for sure. That makes sense.
yeah. It
Yeah.
just sounds more compassionate when you just leave it at the question without the for me.
Please do this. Can you do this?
Yeah. How does
Yeah.
this? Yeah.
Right,
Yeah.
right. So important. Our words and our touch and all that creates that sense of connection. Susannah, have you ever had an experience where you really didn't feel like you were connected to a client? Like you tried, but it just wasn't working?
Oh my goodness. Yes. Yeah. And you can also, I've also been in situations where, you may feel like you're connecting to them and then all of a sudden some switch flipped and you're not. And that happened to me yesterday. I was
You.
evaluating a patient. She was a little controlling. She
Uh-huh.
was a knowledgeable person, but not in specifically my field. And, I always want to send someone home with something very functional after their evaluation that they can start putting into practice, so that they can possibly feel some improvements and tap into that somatosensory feeling. And so I was going over posture and breathing. And we know that, she was an apical belly breather.
Mm.
And, and so I was trying to teach her back body and lateral breathing. She was not having it. She said, I know how to breathe. If you don't have anything else for me, then you're wasting my time. And so at that point, I was like, okay, there was a part of myself that wanted to justify and defend, why
Yeah,
posture and breathing is important. But then I was like, what does the patient want and need right now? They want something more actionable. So let me pull the next thing out of my toolbox. And so, the first thing that popped into mind was how to engage transverse abdominis. So we went over that, and she was very pleased with that. And she, so
yeah,
um yeah, and then we talked about her practice a little bit before she left, and I think that that was really empowering to her because she's actually new to that field. And I think that she's trying to establish herself as a practitioner. So I tried to do what was best for her. But I had to be like a duck afterwards and let that water roll off my back because the approach was a little piercing from a heart that was trying to help, you
right,
know?
right. Yeah. I actually had a client, this is years ago, and I was working in this medical practice, and this client and I, we just did not click. It was like we would talk and uh, we just were not connecting. And I saw her once, and then she came back for a second session. And actually, we both at the same time agreed that this wasn't right.
Right.
And so I'm just like, yeah, I totally agree. And I
There
give
can be a
permission,
win in that,
right,
in
for
helping
you
them
to,
find the right person for them.
right, like I give you permission to walk out the door and know that this isn't right between us. Great. And so,
Right.
yeah, it was, but I love that it was, both of us coming to the same conclusion at the same time. That was nice.
That
Um,
is helpful because then that can feel like a win in and of itself,
yeah,
you
yeah,
know?
yeah,
Yeah.
yeah. But,
Yeah. Especially if you help usher them on to the next thing.
well, in
Um,
that really, we as practitioners really need to um, be empowered enough for ourselves to recognize when it doesn't feel right and to listen to that and to give them the permission to move on and find someone else. Because that's a hard, especially if you're starting out, your new practice, you want the money coming in. But if it is not, if you do not have that connection with someone and it feels off, no good is going to come of those sessions.
and it happens.
It
It
does.
happens. It isn't necessarily a reflection of us.
No, no, it's not. And sometimes I think it's there to help us to learn to stand up for ourselves and to realize. And I think the more you make a stand of like, okay, you're not the right person for me, and I'm not the right person for you. And
Mhm.
if we can do that, then I think the universe starts sending us the right people that are for us.
Yeah, absolutely. And, I wish in school that they did a better job of helping us understand what the legalities are about serving our patients and, what is considered an acceptable boundary for, standing up for yourself. Because there are situations where you have to say, this isn't right for me because of X, Y, and Z,
Yeah. Yeah.
and you don't want that to come back on you, and it can.
Yeah.
So I wish that there was more of a discussion about that. I think that there are some classes that are beginning to pop up about that.
Yeah.
Um,
Su-
but
Suzanne, I want to go back to what you said about oh shoot, am I forgetting it now? Um, when it's not right for the client and you sense it and the client may or may not sense it. I think we feel we can't speak up for ourselves. But I think it's important that we listen to that because that's our intuition, that inner knowingness and like that ugh feeling in your body. Um, I know what I was going to say is that your example of your client, you were trying to get her to breathe, but she was getting pissy and like, that's not why I came
Thought
here.
she thought she knew how to do it.
Yeah.
I know posture, I know breathing, and there are nuances to these things that she was just not interested in. And
Right.
so I know we may not be a good fit because breathing comes into a lot of the corrective exercises that I do.
Yeah.
So
Yeah.
we may not be a good fit.
Right. But you were able to then really sense into what she did want. And I think that's important. That was the point I was trying to make earlier. Sorry, guys, I got a little sidetracked, but we need to be able to tune in. And even when you're feeling that it comes across as like we're just missing each other, like we're talking, but yet you're saying A, B, C, but I'm hearing X, Y, Z, and so we have to, as practitioners, to put our own egos aside and meet our patients where they're at, which is exactly what you did in that example.
And I've done it before. Like, for example, a few months ago, I had a lymphedema patient who wanted things to go a certain way, but they weren't going to unless she was able to, be compliant with certain things that she wasn't interested in doing. And so we had a discussion, and then a light bulb went off. And, I mean, I was not going to continue to see her. And I told her ethically, if she wasn't consistently making improvements, and
Yeah,
anyway, there's a lot of backstory and I don't want to get into it. But we aren't magicians, and I'm
right.
not going to continue to take her money if she wants an outcome that she's not getting. And so we had to have a real heart to heart, and that was an uncomfortable conversation, and it lasted a considerable amount of the session. But oh my goodness, is she flying now? And she was mad at me. She was not happy with me initially, but she did not want to see anyone else.
Interesting.
But she needed to know that, like, I'm not a magician,
Right, right.
and I'm
Yeah.
not going to continue to take your money if you're expecting X result. So we need to meet in the middle.
Yeah. Well, that's important for us as practitioners to stand up for ourselves, right? To not just placate our patients and let them get away with whatever it is. And for us to stand up and stand in our power and say, no, this is what how this needs to go. But it's such a fine line because if we have those controlling patients, it's a fine line of figuring out how can we help them to feel in control and still get them to where we know that they need to go
Yes. Yeah. And
and stay connected to them at the same time.
yeah, absolutely. Um, there's so much, I'm having so many thoughts come to mind, but I think that it's also one more thing that I want to address that is coming to mind for that I learned from another practitioner, is what do you do when you've had a rattling session and you have to move on to the next person and be present with them?
Yes.
And I was going through a particularly hard time in my life, a breakup, and I attended a self-care and healthcare training course that was by Nari Clemens and Jen Vandevent, Jen Ross. And I learned so many skills, so many things that we don't talk about in that class. And one of them was creating a ritual for yourself.
Hmm.
So, some of Nari's suggestions were like having a ritual hand washing
Hmm.
if between patients, but especially after something that feels uncomfortable. I've built in 15 minutes between patients so that I can turn over the room and try to get as much of my documentation done as possible and take a moment to try and center
Yeah.
before seeing that next person.
Yeah, I do. I wash my hands in between every client, and that's part of my ritual. But if it's been an extremely intense session, I also sweep my bowl. So those of you that have been following me, Tammy Lynn Kent's work, Wild Feminine, she talks about the pelvic bowl sweeping. And it is amazing how much as we as practitioners take on other people's energies without realizing it. and we store it in our pelvic space. So just imagining your pelvis, the drain at that bottom, and you are just sweeping away their energy at the end. I almost say, I think of it as flushing the toilet. Like I
That's
flush the toilet and I see it swirling on down and out the bottom of my bowl, out the drain, and just clearing their energy. And it's amazing how grounding and how much lighter you can feel after. I do that after any negative interaction with someone.
It's so good that you're talking about this. I mean, when I started in this field, we didn't talk about energetic exchanges. We didn't even necessarily, I had a professor, Raisiner Bosch, who taught us how to feel energy through our hands.
Wow, that's cool.
And it was amazing because a lot of us asked for him to do a class outside of our coursework because the school wouldn't let him teach this.
Ah,
And it was amazing when we would, he would even start teaching us a little bit of cranial work.
uh-huh.
And we would sense something, and then he would come over and put his hands over our hands, and we could sense it so much more.
Yeah, yeah.
Um, but getting into the field and doing manual therapy, and I guess it's probably some of my own childhood stuff, but doing for others to at my own expense.
Yeah.
And I thought that I know that this sounds so silly now, 17 years later, but I thought that when I was experiencing, when I could feel through my hands and I could feel movement, releases, things happening, that even if I had some sensation in my body that didn't feel good, that was fatiguing, that I should keep going.
Hmm.
And it was in this self-care for healthcare class that, Nari said, ground through your feet, imagine a keyhole wherever it is that you're sensing that at your back, and let it go out the keyhole. And that made such a difference. And
Awesome.
that's that visualization process. There's the one that I'm sure that you can do that while you're working with a client if anything were to come up. And I don't experience manual therapy in the same way that I did then, but I
Awesome.
hadn't been given the tools.
Right. I know. And I feel like that is such a disservice for all of us doing pelvic health because so much comes up and so much is held in that pelvic space. And for us not to know what to do with it, how to take care of ourselves, if we can't take care of ourselves, we're not as optimal in supporting our clients. And so it's so true. And I hope everybody listening into this will do what you need to take care of yourself, to not take things on, to be neutral, compassionate detachment is what I teach in my birth healing intensive program. And that we can be very present, very connected to someone and allow them to have their experience without taking anything on and not feeling drained at the end of the day. So that is a goal. And I want to just put a highlight out. You were talking about how you were not in a good state or frame of mind. And I remember when I was going through my divorce, I talk about that with Kim Bartell this summit about being present with our clients and what presence really means. So it was such a great, great interview. And I want to let everybody know that you are also a part of the summit. So do you want to share a little bit about what we talked about for the summit interview? Give people a little snippet?
Absolutely. We talked about the central nervous system and how important that plays a role in birthing from both a neurological component, also setting our patients up psychologically with knowledge and skills going into birth so that they can tune into their body and maintain their energy levels longer, so that they can listen and report what they need to. And socially, how we can give their support system skills in order to make birth easier and more supportive for them, as well as what we do as practitioners that can both hinder and help the person and their nervous system. So we talk a lot about, yeah, neurological social interplay.
It was so good, you guys. So please make sure you check out the Birth Healing Summit this year. Check out Susanna's interview. It was so good. And Susannah, thanks so much for being a part of this podcast, for being a part of the summit this year. The summit registration will open the end of March, sorry. The summit starts April 7th. So we'll look forward to seeing everybody there. And Susannah, hopefully you'll be able to join us for the live Q&A with the speakers. We'll be setting that up
Oh,
too
I
during
didn't
the
know that
summit.
was a thing. That's
Yeah, yeah. It's a really fun event. I absolutely love it. And we're going to do it on Zoom this year, not Facebook. So I've done it always Facebook Lives in the past, but we're just going to set up a Zoom link and send everybody out that is a part of the summit the Zoom link, and we can all join there. And we'll have the speakers on, and people can ask questions live. And it's such a powerful
Oh,
discussion.
I'm looking forward to it.
Yeah, yeah,
Thank you.
yeah. We'll be setting that up here soon too. So thank you everybody for listening in. Thank you, Susannah, for being here. And we will see you all on the next podcast. Take care, everybody. Bye-bye.
Bye, Lynn.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.